I will turn it over to Cindy. Take it away.
All right. Well, thank you very much for having me. I truly do appreciate the opportunity to present for our friends over in California on this dreary day in Chicago. So, disclosures, I have nothing to disclose and no conflict of interest. Disclaimer, wanted you to know that number one, because a lot of this information comes from Medicare, and as you know, Medicare can change things in the drop of a hat. But everything that is in here was current as of yesterday. Also, reminder that some of the coverage and the information that I'll be talking about may be different in different commercial carriers. So you need to be able to check with what your commercial carriers are doing. And then the third one, this really is strictly for educational purposes. Nothing should be taken as legal information. A little bit about myself. I know you obviously could have read this in your in the invitation and the registration page. I've been with the AOA about 8 years. Before that, I was at the AMA. But more importantly, I spent the majority of my career managing physician practices. So I do understand what's going on. I've been in the trenches, and I personally think that helps. My practice management hat is on more than any other hat. Maybe my grandma hat may be on a little bit more lately, but I keep my hand in the practice management arena. Number one, keeping my certifications current, but also so that I know what's going on. What we're going to go over today are basically the changes that started in January of 2021, which I certainly hope you all were aware of. We're going to discuss the impact and things that you need to do to change your workflow, most likely in with your documentation, how best to document for an OMT performed on the same day as an E&M, and then finally about the denials and appealing those. So let's get to it. How did we get here? Believe it or not, this all started in 1992, and some of you probably are too young to even know that the RBRVS or the E&M codes didn't start till 1992, which in my head doesn't seem like that long ago, but I guess it was. Well, at that time, the codes were introduced. 1995 was when CMS went in and did a little bit of revision, and they produced guidelines that they worked with the AMA on so that everybody was doing the same thing if they followed those guidelines. 97, they added on the single specialty exams. And then 2018, things started to change again. CMS proposed major changes to the E&M codes and payment that they wanted to start in 2019. There was an uproar across the industry. The AMA, CPT, and RUC committees decided they better form a joint workshop to look at everything and see what CMS was proposing. Well, by November, we knew that there was going to be an overhaul of what they proposed, and the guidelines were changed or postponed till 2021. 2019, they presented us with what those revisions were going to be. They also adopted those revisions. December of 2020, they went into law. So Congress passed it. This is what it is. And they started January 1st of this year. Of course, being CMS, they started it and then a week later released the guidelines, and they had to change some of the guidance they had given, which they had failed to include. but we have it all now. And so we're here. But why? Why did they have to do all this? Why did they have to mess with you? You had everything down in your head. You knew what you were doing. Well, number one, the E&M visits make up 40% of the Medicare payments. There were a lot of upcoding errors that were found. The majority of clinicians, providers use the codes. And they, obviously the guidelines really hadn't been updated. So they needed some tweaks. And the big thing that they were hoping to do with these was to relieve some of the administrative burden that has been placed on you. They estimated that the changes are going to save 51 hours of your clinic time per physician. Personally, I think it's a little too early to tell whether that's really going to happen, but that was the premise of this. They estimate that the result of reduction of 2.1 minutes per visit. So we'll see. We'll see what happens. So the things you needed to know, and like I said, I'm hoping you know this, the gist of what happened was that 99201 was deleted, can no longer use that code. The codes that are impacted, there were 9 of them, 99202 to 99205, 99211 to 215. So basically your outpatient visit codes, office visits. Now, one thing to note here is that these were the only codes impacted, and notice the yet. My guess is more are coming. They're all going to work this way, okay? It does not just apply to Medicare, it applies to the commercial payers as well. They went along with it. They also added a new prolonged services code. And again, as I said, it's only the E&M visits so far. So now instead of basing your choice of code on your exam and different things like that, you have a choice. You can either base the level of code on your medical decision-making or on the time that you spend. So it's up to you. Either one is perfectly acceptable. So we're going to go over time first, okay? This, in most people's minds, sounds like the easier way to go, but we're not encouraging it. So the meaning is your specific time that you used to have to spend if you were going to code by time using 50% on counseling. That's no longer in effect. So you can bill on time, using time for anything, whether you counsel the patient or not. Trick is, it's all got to be on the same day, which is again, okay. And it's only physician time. So it's not your medical assistant or anybody else that takes vitals when they bring the patient in the room. That's not counted on time. It's your time, both in face-to-face and non-face-to-face, okay? So that could prepare, you're looking at the chart ahead of time before you go in. Maybe in the morning you have huddle with your staff and you go over all the patients that are coming in for the day and you spend 5 minutes on each patient talking about things like that. That could be included. Reviewing their history before you even walk in the exam room. Okay, then you go in the exam room. You're visiting with the patient. Maybe you're counseling them. Maybe you're counseling the family. That would be included. You're doing your exam. You're ordering tests. You could do your chart. If you do your charting in your room and finish off on that, that's okay. If it's something that you do later on and close out that visit later in the day, you would make notice of that and keep track of the time that you use later in the evening to do that. Okay, so that is what is included in time. Remember, it only pertains to the E&M visit, not a minor procedure or OMT that you might be providing on the same day. You cannot count that in with the level of E&M. This is a little bit of the change of what we are, where we went from 2020 guidelines to the 21. So the times have changed. As I said, the 99201 was deleted, but you see that we're given a range now rather than specific time frame. Now, if you are doing this, you want to make sure that you're being honest. I will tell you that one of the things that they will be looking at, if all of a sudden they see a chart that says, well, I spent between 15 and 29 minutes with this patient. They're going to question them. They're going to want you to break that down. How did you come up with that 15 to 29? Or is it just you looked at this and said, oh yeah, it was between that time? They want to know specifics. So keep that in mind. Established patient, again, 10 minutes to 10 to 19. 15 minutes went for the level 3, 20 to 29 minutes for the E&M. For the level 4, 30 to 39 minutes. So you want to pay attention to those. And then the prolonged services. So this is an add-on code that they've given us now. This can only be used if you're billing the 99205 or the 99215. If you're billing to a commercial carrier, you're going to use the 99417. If it's a Medicare patient, you're going to go to the G2212. And basically, it's any 15 minutes above the time. Now, of course, it couldn't have made this easy. CMS didn't agree with CPT's timing. They agreed the 15 minutes, but what it is that CPT will you can start your 15 minutes once the minimum time in the primary. So where the 40 minutes you would add on. Whereas if you're going to bill Medicare, you're going to bill those 15 minutes after the ending time in the column. So because this is between 54 minutes, you wouldn't get to add the G2212. This one, if it's 56 minutes and more. So see the difference in here, how it's working. So one more thing you've got to kind of pay attention to and know which one you're going to bill if you are going to be using it. Or your biller should know this. Medical decision making. Okay, so you know what medical decision making includes. You've been doing it your whole career. You're going to establish diagnosis. You're going to assess the status of the condition or the problem that the patient came to see you for that day. And you're going to select the management option. How are you going to do it? What are you going to do for this patient? What are your options? Well, they've come up with a new spreadsheet to look at, similar to the 95 and 97 guidelines that are still in effect for all other codes. That's where I think the burden comes in, is having all of these things working at one time, but they didn't ask me. So the new tool is created. It looks at the number and complexity of the problems addressed at that visit. The amount of the data reviewed or the complexity of the data reviewed and the risk of any complications based on that problem of the day. And your medical decision-making is what is going to provide the medical necessity. Why did that patient need to come in to see you that day? And why is this level of E&M being charged? And why do you deserve to be reimbursed for it? So you're going to prove your medical necessity by documenting your medical decision-making. And we'll go into that a little bit further on. So this is the new chart. This one obviously is from the AMA's website, different columns. You've got the different codes here, the level of medical decision-making, the number and complexity of the problems, the amount or complexity of data to be reviewed, and then the risk of complications, okay? And as I said, this is available on the AMA's website, and actually in your CPT book, in the beginning of the new CPT books, they actually break it down a little bit further. So, clarifications on it. Again, problems addressed. And this is one of the things that when I said that when the rule first started January 1st, some of these, they had all the wording, but they didn't provide us with definitions or what do these actually mean. These are some of the things that they provided us the week later. So problems addressed. Is it unstable? Well, that's an easy one. Patient is not at their treatment goal. Okay. They're stable. Is it chronic? Okay. What does that mean? Well, so basically what you have, and if we're going to break down what's on the table, and when I was telling you how we got here, I mentioned to you how CMS sent out all the rules and then a week later came back and said, oops, we forgot to include something. What they forgot to include were all the definitions of these things that they had come up with. So in the problems addressed, unstable, well, that one's an easy one. Obviously a patient that hasn't reached their treatment goal. A stable position that's chronic would be expected to last at least a year, but is stable. So an example of that would be a well-controlled hypertensive patient. Column 4 is the unique tests. And this actually is a benefit of the switch in that it used to be that if you read a bunch of x-rays on a patient, you could only count, no matter how many x-rays, as 1 point in selecting your code. Now it's every unique test. And what they mean by unique test is if there's a CPT code for it, it's a unique test. A CBC, a BMP, a TSH, okay? Now, identify each test reviewed. Those are reviewed that you didn't order, okay? So a test that came in from somebody else. Also, for these unique tests, if you ordered it, you get the point for it. But that point includes when you review it, whether it be at that visit or whether it be in the follow-up visit. You can't double dip. You ordered it, they're going to assume you're going to read it and look at it, okay? Identify each external note. If you get a message from or notes from a cardiologist and a pulmonologist, that's 2 points. If you then have to talk to the patient's family, or if it's a Medicare pediatric case, do you have to talk to the parent or do you have to talk to a caregiver to get the full story of what's going on? That's a point. Record if you're a personal interpretation of a study, okay? Again, that's a test that you have not ordered, but maybe you interpreted it yourself. Maybe you looked at an EKG and made note of what was in there, and based on what you see in that EKG, you make a decision. That could be used. And then number 5 is risk, okay? Your thinking process. Basically, everything that's in your head, they want to know what you were thinking. And if you can document it, you can get the point for it. So the HCC coding that you're doing for your Medicare Advantage patients, start using those codes for every patient that you see. they're showing how critical that patient is or how sick that patient is. And if it needs that's something you're addressing at that visit, use that. The clinical course with or without treatment, is there risk involved? If you do something or if you don't, what are the risks? What could happen if you do it? What could happen if you don't? Okay, so those type of things. And the new one that's added is the social determinants of health, or the F codes in the ICD-10 book. Okay, do any of those make a difference in the patient's diagnosis or in your considering of what needs to be done with that patient? You know, if you're ordering physical therapy and the patient doesn't drive, is that going to prevent him from going? You know, things like that. If the patient, you know, can't afford a medication that you want to give them, is that going to make notes of those things? Right? And this is just basically, you're going to be selecting 2 out of 3 on for an E&M. So this, I basically just combined a little bit of the time. I added a column to what was in the new tool. So for 99202 or 99212, here's the time that goes along with those visits. The straightforward, minimal of 1 self-limited or minor problem is the problems addressed. Data, you're not going to be really reviewing anything. And there really is no risk, you know, so it's a straightforward exam, and this is what it would be. Okay. These are what the CPT descriptors are in the new books. So you can see that this is a big thing that they're stressing now: a medically appropriate history and or exam. Okay. Low-level medical decision-making. And when using time, so this is just how they're changed, how they were described in the book. So just an example, so you're aware of it. So, and basically, all of this that I've just told you, the medical decision-making, the time, everything else, all comes down to the documentation. Everything. That's the bottom line. So your E&M documentation, what do you include in an E&M visit? All right, number 1, your history and physical exam, it's still necessary. Nobody said you don't ever have to do it. It just says it has to be appropriate for the reason that the patient came to see you, for that chief complaint. So you don't just check a bunch of boxes. It has to be the things you're looking at are because of that chief complaint, what they came to see you for. Document only what is medically necessary. If they, you know, did you need to, I don't know, look in their ears because they came with a twisted ankle, that type of thing. Okay, you don't need to just check boxes. And one of the things that we've heard from some of the older docs is, hey, I can dictate again. I can put this all in a narrative into my records. This is great. Again, problem pertinent. What did the patient come to see you for that day? You want to make sure it maintains the clinical integrity of the visit. It's everything in there making sense. And then include the 360 view. Again, is look all around. What is that? Is anything from the social depression? All of that goes into the exam, okay? Look at it all. All right, you know how to document. You're going to do the location, the quality, severity, the duration. Those are things you know. This is where you're going to put the social determinants. Another one that we're seeing now being included is COVID. Whatever they're coming in to see you for, could it possibly have anything be related to COVID? Could it? Could it not? Would it make a difference if it was? Those are things that you're going to put there. Your subjective views, still part of the SOAP note. None of that has changed. Physical exam, only what is needed. Again, relevance to that chief complaint. Appropriate based on, again, the chief complaint. And that chief complaint, this is something that we see in records that come in for us to review. A lot of docs are putting in their own words of what the patient is there for. The chief complaint should be why the patient came in the patient's words. It's usually going to be, what are you coming in for? Well, obviously, because Dr. Jones told me to come in isn't what you want to hear. What are you coming to him for? Is something hurting you? What is it? Okay, I've got a backache. I've got a headache. That type of thing. Again, this is where you're going to use your chart descriptions, okay? You're going to be specific with the segmental dysfunction, compensatory changes, and the rationale for treating, okay? This is where it's going to be where you're going to let somebody know, the next person that needs to pick up that chart is going to know how you got from that chief complaint of a headache to why you had to treat a lower extremity. How did you get from A to B? It's kind of like that old game with, shin bones connected to the whatever, however that goes. But you need to put that all down now. So whatever was in your head now needs to be in your documentation. Assessment, okay? That's the analysis of your findings, okay? So any possible interactions, comorbidities, again, your thought process. The history of the original complaint. Have you been treating this same low back pain for 6 months? Has it gotten better? Has it gotten worse? Based on getting better or worse, is there something else you're going to recommend and why you're recommending it? Because it got better, because it got worse, that type of thing, okay? This is where it's going to help establish your medical necessity of continued OMT. If you're treating them on a regular basis, if your notes always look the same and your assessment is the same, not saying that this is getting better, this is getting worse, there are changes that you're seeing or anything, you're going to end up with problems from auditors or denials because of it. They want to know why you're continuing to do this, why it's medically necessary. Is the patient better for 6 months? Is the patient better for 3 weeks? That type of thing. So your plan is at the end. Okay, what are you going to do? Is there an x-ray that you need? Are you going to order a PT, a hot pack, OMT, Tylenol? Okay, follow-up visit in so many weeks if your back pain worsens. Follow up within 3 weeks to reevaluate your back pain. Those are the type of things that are in your plan, okay? And that is the end of your E&M. That's it. So our pre-service was the review of the medical history, okay? This is what you looked at before you went in to see the patient, most likely. Then the inter-service work, okay? This is when you talked to the patient, you did your exam, made sure the medications were working, things like that. Your post-visit work is you're going to complete the medical record. You're going to handle any treatments or failures or, anything like that. This is your E&M. It stops. That's where it stops. All right. Now, OMT. All right. You recommended OMT for that patient. Patient decided to proceed with recommended OMT today to treat the somatic dysfunction found in, you could either list the areas or say in today's physical exam when evaluating back pain. Yes, is it more to document? Absolutely. But can there be any question in anybody's mind what just happened? if a document looks like this, it's pretty clear. Document consent obtained, you're going to put that in there. You're basically going to make your OMT note look like a procedure note. OMT is a procedure. It is considered in the CPT book as a minor procedure. Make it look like one. Patient was put in such and such position to treat such and such area. Such and such technique was used. Okay, this is what needs to be there. These are the codes, which I know you all know. These are the ICD-10 codes for the somatic dysfunction. Okay, this is what your pre-service work for the OMT. So you already did, you basically from your plan determined that you were going to do OMT, but now you're going to decide what techniques you're going to use. Okay, now, do I know that that's in your head? Yes, but that is what you're going to be putting down now. You explain the intended procedure to the patient, tell them what you're going to do, why you're going to do it. Okay, then the inter-service. Patient in such and such position. Again, this is what's covered, okay? And then the post-service work, documented in the medical records, follow-up and such. That's really it, okay? Now, one of the things I do want to say is the medical necessity, besides your documentation, is going to, you need to have the ICD-10 codes because they certainly will help. If you're going to be coding with non-specific or vague coding, it's not going to help you. So you want to be able to take that, your ICD-10 codes, and I think when ICD-10 came out, a lot of people just went with crossovers and whatever there is in their computers, that's what they're using. You want to be able to maybe go through the ICD-10 book and look at the areas that you treat and see if there are things, codes that you could be using that are more specific. Because those are the things you need to be adding. And those are the things that are going to prevent you from getting denials for, you know, Anthem saying that you can't have the same diagnosis or you can't see the patient for the same issue within however many 60 days or whatever it is that they're saying. So these are the type of things you got to pay attention to. So tips, always separate your E&M from your procedure note. Again, you're going to make it more defensible if somebody else has to look at it. And I understand that there's going to be some of you that are saying, I was taught this way and I've been doing it for so long. It used to be that the physician's medical record was you documented to trigger your mind so that you knew when that patient came back to see you, what you did last time. Okay, that's what your documentation was for. That's all it was used for. Nowadays, that's not the case. Nowadays, your documentation is a what if. What if something happened to you? Or what if someone needed to look at that record? Whether it be an auditor, whether it be another physician, whether it be the patient themselves, they're going to be able to figure out what you did and why you did it. That's it. So that's what you need to document. Never bill more than one E&M service per physician per day. Okay, and never use modifier 59 instead of modifier 25 for OMT. That's just not acceptable. Okay, with telemedicine, because of all of that since COVID, you want to make sure that you include, you want to, number one, look at your different payer policies on it, stay up on those and make sure that you're using the correct modifiers and place of service and all that. But the things that you want to include are Was it audio? Was it visual? Was it both? What platform was used? Things like that. Did the patient know that whatever you were using was HIPAA compliant or wasn't? Okay, those are things you want to have documented in your record because the telemedicine audits are coming. The insurers now have time to go back and they're going to want to see everything that was done now. We knew it was going to happen and they're starting. And remember, it's all about the why, the clinical presentation, appropriate assessment, okay? If they're, like I said, if they're coming in for a small thing, you don't need to do a complete history and physical. And what your plan is, okay? Tell the story. And again, this, if it's not documented, it didn't happen, that hasn't gone away. Again, document the what if and make it defensible. If you have everything written in that chart, it's going to be really hard for someone to say you didn't do those things. Yeah. All right, these are some case studies that we had developed. So the first one is based on medical decision making. So you've got Dr. A sees a 38-year-old female, low back pain that occurs during her menses. She's taken oral contraceptives in the past, no longer wants to take them. He asks the normal questions that are appropriate, no evidence of any compromise. He does see somatic dysfunction of the sacrum and the pelvis. So he expresses concern about that and recommends the OMT. Patient agrees to have the OMT performed and they do the 2 regions. So if you're selecting this based on the E&M, how would you code the E&M visit? Well, we'd look at our chart and we say here, okay, we've got low back pain during her menses. That's one acute complicated area here. And then we're going to come over. We didn't look at any records, so we didn't look at any data. And so what's the risk? Well, there really is very low or no risk based on that, right? So we needed to have 2 out of 3 areas. So we know that it's a medical decision-making of low impact. It's a low level, and it puts us at a 99213. Now, we got case study number 2. Again, we're going to do this by medical decision making. This is an 84-year-old man. His adult daughter came with him, and he's there for chronic severe low back pain. He's had x-rays, MRIs, lab tests done. He's had all sorts of numerous medications that he's taken. Physical therapy, chiropractic manipulation. I mean, he's had it all. Those were not successful, but some OMT has been helpful. So the doctor reviews everything. He talks to the patient's daughter, reviews the history that she filled out. And he says that he does feel that the OMT, patient says the OMT has helped him in the past, and he feels that it'll help him take care of himself in the future. So the doctor completes the history and exam, make sure there's no other neurological deficits. Again, he finds the somatic dysfunction, recommends the OMT, and the patient and the daughter agree. So doctor does it. Turns out he has found 5 regions that he wants to treat for somatic dysfunction. So how are we going to code that? Well, again, it's 1 or more chronic illnesses. So it's still the low back pain, okay? Now, over here, if we used providing OMT, we already found out that it's at low risk, right? But because we looked at all that data, we now can use in this column. So now we have 2 out of 3. Okay, this brings this up to a 99214. Okay. So. All right, now let's look at the same ones based on time. Okay, so this is our 38-year-old patient with the pain during menses. Okay, so the review of the previous progress note, 3 minutes. Then the exam took about 8. The documentation took about 5, and the OMT took 10 minutes. Right, based on time, what are we going with? Now, hopefully you're all adding this in your head, but we're going to go with 10 to 19 minutes, okay? A 99212. And why is that? Because that 10 minutes of OMT, we can't include in the E&M visit. E&M visit is only the amount of time spent on the E&M visit, not the procedure. Okay, we're 9, this is a level 2. Okay, now we're at our 84-year-old man. Spent 20 minutes looking over all of his work, all of his previous records. Okay, that took a good 20 minutes. And then the history and exam and the discussion took about 12 minutes. Completed the documentation in 5. And then the OMT took about 15 minutes. That brings us up to a 4. Again, why? Because we can't include those 15 minutes that were spent on the OMT treatment. And only include the time spent on the E&M. So let's compare them. All right, so for medical decision-making, looking at the same chart, we were able to do it in 99213. If we build that one on time, we went to a 99212. Okay, those are things you want to consider. For case study number 2, the medical decision-making was a level 4, so was the time. Again, sometimes one works better than the other, sometimes it doesn't. You have to decide. Okay? That's your decision. Denials, appeals, and audits. All right, denial is a refusal of a payer to honor the request to pay. Okay, it can be the entire claim or it can be one line item in the claim. 75% of providers still rank denials as the greatest revenue cycle challenge. That is across all specialties, okay? 65% of denials are never worked. This continues to amaze me. Because 2 out of 3 of those denials are recovered. In other words, they're overturned if they're denied. So I don't know why people aren't appealing them. Okay, an audit is basically the looking for compliance. Are you doing what you said you were doing when you submitted that bill? Is your coding correct? Is your documentation correct? Did you follow the payment guidelines based on that insurer? Okay. They're payer focused. Each payer could have a different way of doing things and require different things. That's why one of the hardest parts is making sure that your managers or your billers stay up to date on all the different things that the different payers require. And basically usually the audits are checking for medical necessity and to prevent fraud. We do know that modifier 25 is continuing on the OIG's radar, is the #1 misused modifier. So that's why we see so many denials with the E&M and the OMT. So the top denials, duplicate claim. A duplicate claim is submitted when the denial comes back and your biller just resubmits the same claim. Okay? An insurer keeps seeing that, you're being flagged. You've got a lazy biller. That's not what you do when you get a duplicate, a denial. If you're getting a denial, you want to appeal that denial. You don't just send back the same thing and expect a different outcome. Now, if there is something that needs to be corrected on that claim, then you send a corrected claim. Okay? Timely filing. Make sure that your billers know what the laws are in California or with that payer. Okay? Follow the payer's policy. If you're appealing, is it based on the initial denial or the date of service? You got to know those things. If a patient is no longer has that benefit and all of a sudden it gets denied by one insurer, and you now send it to the correct insurer and they come back and say to you, you missed our timely filing. Well, what you need to do then is your biller needs to say, okay, this is who we billed originally, because this is who the patient told us was their insurer. So we met the timely filing. We didn't know about you till this day. That will help you in your appeal of that one for timely filing. Okay. Coordination of benefits. Make sure your billers know who's primary, who's secondary, and how to figure that out. And the policy coverage errors that are going on, a lot of that is because employers may not notify the insurer that the patient no longer has that insurance, or that their employee doesn't have that insurance, is no longer employed. Okay. Authorizations required. If a pre-auth is required for OMT, you better make sure you get it. You got to follow the payer's authorization process. Just because one payer wants you to do it this way with a call doesn't mean the other one wants it that way. The other one may want you to go through a portal or something. Okay. And then the frequency limitations. Those are things that are out there. Pay attention to them. If you know that this insurer has that, and the majority of the time we usually see those in self-funded plans, so employer plans. Make sure you stay within that guideline, but also understand that the majority of the time, those don't say 15 OMT treatments a year. They say 15 manipulation treatments a year. Now, what can fall under manipulation? Physical therapy, chiropractor, OMT. So if your patient is getting all these services, you may meet that limit fairly quickly, early in the year. So the AOA denials and issues that we hear from. E&M service performed on the same day as OMT. OMT service performed on the same day as an E&M. That should say E&M. So sometimes they deny the E&M, sometimes they deny the OMT. Non-covered service. This is something we're seeing now where the denial comes in and it says it's for a non-covered service. Now, a non-covered service does not mean that they've bundled the OMT into the E&M visit. What that means is that plan that that patient has does not does not cover OMT. Now, I will tell you that happens. Believe it or not, a few years ago, the AOA, the insurer for employees, didn't cover OMT. When the HR signed up for the plan, they didn't realize what to look for. And until the first employee went to get an OMT treatment, nobody knew it. So at that point, obviously the employee went to our HR department HR contacted our insurer agent and said, hey, we got to add this onto our policy. That's why if you call for help and someone tells you you need to get the patient involved in those cases to go to their employer, it's the employer that has chosen what they're covering and what they're not. Okay? And then one of the latest things that we're seeing, and this one took us a while to actually get the gist of it, they're saying the diagnosis code does not match the claim. Think about that. It's like, what's going on here? All right, so we were finally able to figure this out when we asked to see everything. Send us the claim you sent in, send us your denial, send us the appeal, all of that. And it turned out that the doctor was treating 8 to 9 regions, but on his claim form, he was only putting 3 somatic dysfunction codes. The insurers wanted to see. This insurer wanted to see that. They wanted to see every region as a diagnosis code for that somatic dysfunction of those regions. This is a new one, so be on the lookout. Denial tips. Again, avoid the duplicate claims. Again, and then so many of the insurers nowadays are using Availity. Make sure your staff is using those. That portal can tell them a lot of what's going on with your claims. Appeal all denials. You know, and I understand the administrative burden. I understand the, you know, the time it takes. But the only way you're going to, you know, be able to get paid for the services you are providing is to abide by your contract with that insurer. So, and then follow the payer specific appeal process. Again, they're all different. Don't just use a standard appeal letter. Don't think that it's always the bundling of OMT and the E&M, because it's not. And so if they've given you a different reason for that denial, you make sure that appeal letter supports why you are going against with what they are saying, why they are denying it, okay? If needed, appeal through all levels. If you're sure your documentation supports what you build and it goes along with their policy and it's a covered service, keep going. Notify OPSC and let them know. Notify AOA if you need help, but don't let it just go to the side. And then again, with the ERISA or employee-based, have the patient get involved. Again, this is more about the non-coverage. So look at that. So the audits. Who are the audits? Who's auditing you? Or who could be auditing you? There's a whole bunch of different people. And unfortunately, you need to be able to know who they are, and what the result of that audit, the impact it could have on you. And I will tell you that some of this information that comes saying you're under an audit can look almost like an advertisement or almost like a form letter. So whoever's opening your mail, make sure it's not just your front office staff that maybe doesn't understand all of this. You know, make sure whoever opens it understands so that they can figure out what it is. So the risk areas, okay, the big one we're seeing now. Did you provide OMT during the president ban on elective procedures? Okay, the insurers are now going back and looking. And they're going in and they're seeing that an NMM specialist performed all these OMT procedures. Well, were they all urgent? Were they life-threatening? Why did they have to be done? That's what they're looking for. Okay? Again, the COVID audits, those are coming through now with the telemedicine. They're going in and looking. We paid you. We agreed to do it, but now we want to make sure you abided by all the rules you were supposed to. Okay. Again, the medical policies, know what those insurers' policies are. I can't tell you how often somebody will call and say, yeah, I've suddenly been getting this. And it's like, well, there was a notification. Are you sure you didn't get anything? You're seeing, nope, nope, nope. And then we find out that it had been notified, 6 months ago or something. Those are things your billers need to be looking for. And those are things that they can sign up for to just get automatically. Or that they can look at when they go into the physician portal on the insurance. Again, you're going to be careful. You need to look at your time-based codes. You're going to start billing with time. They're going to come in and look at those. That's pretty much a given. Patient complaints can trigger some of these audits. So, some insurers have been known to call a patient up and say, hey, we see you saw Dr. Jones this day. What did he do? Oh, I don't know. I only saw him for like 10 minutes. It was a real quick visit. And you did a level 4. Okay, this is where your documentation is going to come in, where you're going to say to that insurer, okay, this is everything I did on that patient. This is what was done. Maybe to the patient, they think it just happened, but this is what's done. So those are things that can trigger them. Tips, always ask for an extension. I don't care what audit comes in, they tell you you need 30 days to, or 10 days to respond. Send a letter to them, an email to the person that emailed it to you, or if you get the email, hard copy, certified, telling them you need, another 10 days, 15 days, 20 days, whatever it may be, due to shortage in staffing, to gather the information you're requesting. Ask for that extension, okay? Create an audit checklist so that you know everything that they're asking for and making sure that you're providing what they're asking for. You can't not give them. If you're contracted with that insurer and they're asking you for this information, you need to give it to them. Bottom line, you sign the contract, okay? Keep copies of all communications from start to finish. If you have a phone call with your provider rep and your biller goes back and forth with the provider rep, have her follow up with an email to that provider rep saying, thank you for talking to me today. To reiterate, this is what we discussed and this is what the follow-up actions are. Keep track of all that, okay? Page stamp, date, everything that you do, okay? If you're sending something in, you want the date on it on every page, even though your EHR may not put it on there. When you print that out to send to the auditor, you write the date and the page stamp, the stamp of the number, whatever, copied, scanned, save all that. And review your records before you send them out. Don't just send them out, look at them. Maybe there's something in there that, now there's nothing you can change in it, but maybe you'll understand something of what they're looking for, okay? If it's something that you're doing, if you're doing a handwritten note, send a typed transcript along with it. Help them. If you're sending something and they're saying you didn't do 9 and visit 9 regions, highlight all the regions in your documentation, right? All of that. You want to include all that. So some of our sources, these are where you can look for any of this information that I've provided. Our case studies were developed by Dr. Boozer, Dr. O'Connell, and Dr. Warner, who are our OMT E&M gurus who make my job easier because they help with whatever I need. And then the resources. This one, I don't know, the physician support line. This was actually developed by a DO. The phones are all manned by physicians should you need help. There is help available for you. And then AOA or AOIA Physician Services Department. These are some of our on-demand webinars. And then we actually have 5 coming up in November that you may want to take a look at. The one on November 9th, latest in COVID-19 related employment matters. That's actually free CME. And that is going to talk about, okay, do you have to see, a COVID patient? Does your staff, who pays if your chart builds something because you didn't, everybody isn't vaccinated, who pays for it? Does the physician, does the employer have to pay for it, or does the staff person that didn't get vaccinated have to pay for it? Those type of questions are going to be answered. And then we're going to have the ICD-10 changes. Again, remember I told you how important those are. We've got our first one coming up November 4th, and then we're doing a combination of the coding updates, both CPT and ICD-10 at the end of the month as well. So that is everything there. And I thank you. And I think now, if there's any questions.
Thank you, Cindy. Glad we were able to keep going after our little hiccup in the middle there. There was one question in the chat box. Do we need to list the 98927 code with every adjustment?
No. And in fact, your code basically isn't listed in your documentation. Your code is more at the end or on a super bill or something. You don't necessarily have to have that code in your documentation. You have to list all of the different regions that you treated, but you don't have to list the actual code next to it.
Very good. All right, I don't see any other questions in the chat box.
One of the things I will tell you, just as long as we still have a few more minutes, a survey was done, an informal survey of a multi-specialty group in New Jersey.
Oh, I think Cindy froze again. Seems to be the way today is going. We'll see if she unfreezes here. But if not, thank you everybody for coming today. As mentioned previously, we will have the recording up on our YouTube channel. Give us some time for that. We do some editing to make that all work. And I think with that, we will wrap it up for the day. Thank you very much.